Hi, my name's Wendy, and I'm going to talk to you, about the last 15 years of work that we've done in knee replacement, and I hope you find this interesting. If you do have any questions as I go through, please feel free to pop your hand up and interrupt me, and I'm happy to answer them. Right, so I'm going to talk to you about the studies that we've run and the implications for you as primary care practitioners. So I will say that all this work has been funded by the National Institute for Health and Care Research through the various themes and grants that we've got set out there. And we are very grateful to NIHR for funding this work. So I'll start by just telling you a bit about knee replacement surgery. And for those of you who know everything about it, I'm really sorry if I'm teaching you how to suck eggs, but I thought I'd just give you a bit of a base to go on. And then I'm going to talk about STAR, which is support and treatment after joint replacements, and our most recent work on my knee plan. So to begin with, total knee replacement. Why do we do it? Well, this is to reduce pain and improve the function which is caused by osteoarthritis. And 98% of people who have knee replacement have it due to osteoarthritis. The National Joint Registry tells us that it's about 1% for rheumatoid arthritis and another percent for trauma. We also know that the average age of a person having a knee replacement is about 70 years. This is an older population, and there's about a 47 to 65% incidence of multimorbidity in these patients. 55% are female. The average BMI is just under 31, and it's done a little bit more often in the right knee than the left. And interestingly, about 1% of knee replacements are done with both knees at the same time at select centres. It's also the second most common major operation that is done in the UK, and that's after gallbladder removal, and hip replacement is down there at number 9. So that's 110,000 total knee replacements in the UK every year across England, Scotland, Wales, and Northern Ireland. Some of that is from the National Joint Registry, but also from the Scottish Arthroplasty Project. Scotland reports their knee replacements and hip replacements a bit differently than in England. So knee replacement, this is successful for most patients. This is one of the top 3 most successful operations that is done, and that's after cataracts and hip replacement. So I always have to stress knee replacement is a great operation and most people are really, really happy with the results. That is not what my work is about. My work is about those who don't do so well. And we know that 1 in 5 people after their knee replacement at 3 months will have chronic pain. This is incredibly disappointing, especially for those who have been on a waiting list for a year, 2 years or more, waiting in pain, finally having that operation that they think is going to relieve their pain. And then 3 months later, when they would expect to be feeling better and starting to get back to their normal activities, regaining function, they are still in pain. And people with chronic pain have a much worse quality of life. They have much higher primary care costs and more frequent prescriptions, and this affects about 20,000 people every year. They also struggle to make sense of their pain. And this is often due to thinking, well, this was supposed to make it better. Why am I still in pain? They will often blame themselves and feel abandoned. A lot of this is because they go to their surgeons and they say, well, pain is a normal part of recovery and your x-ray looks good. And what I found in my work is patients will say when they are part of a trial that they're so glad that they could be doing something because their surgeon said at 6 weeks, well, it's going to be painful, but you'll get better. Your x-ray looks fine. And they say they go back to their GP and their GP says, well, your surgeon told me that it's normal and your x-ray looks fine. So what do you want me to do? And this is a huge source of frustration for the patients when they're in pain, and they just kind of feel that no one believes them and they're all on their own. So this is where we start STAR, support and treatment after joint replacement. And what I'm going to try and sum up in about the next 10 minutes is 10 years worth of work, which is summed up in this program grant report. So if there's a little bit more that you want to know about it, you can go to the NIHR library and search for the STAR knee program and look at each of the work packages in detail. What I want to tell you about is the nitty-gritty, the meat and potatoes of this, which is the STAR care pathway, the intervention that we developed tested, and then put into usual care, starting from a systematic review, developing the intervention, testing it in a randomized control trial, undertaking stakeholder engagement, and then using that to run an implementation pilot to test the care pathway in usual care in an NHS hospital, develop a training package, and then further put that into usual care in the NHS. So we start with this article by Andrew Beswick. What proportion of patients report long-term pain after total hip or knee replacement? And the key message of this is that unfavorable pain outcomes are reported in the best quality studies in about 20% of patients after their total knee replacement, compared to 9% after total hip replacement. So this is quite a problem, 1 in 5. So this paper is from 2012, and I'm part of the team that's actually just updated this paper this year, and it should be published early next year. And unfortunately, the result is still the same. So I can tell you that it's 22% of patients now report an unfavorable pain outcome 3 months after knee replacement. So not much has changed since 2012. So to address this, we developed a complex intervention, which is the STAR care pathway. It's a complex intervention because chronic pain is multifactorial and you just can't fix it with one thing. So we went through the complex intervention development program. If you want to read more about how we did develop it, you can have a look at this paper. Essentially, the STAR care pathway is a 3-step process, which starts with screening. How do we find these people who are in pain after their knee replacement, and how can we find them in a way that works? Because if we go to the surgeons, everybody sees them at different times post-op, and we need to find them at that 3-month time point. Once we find those who are in pain, they need to be assessed to find out what the source of their pain is and referred on for treatment. They also need to be followed up to make sure they don't slip through the cracks. So we've got a follow-up built into that. So that's a very rough outline of what the care pathway is. In more detail, we identify patients with moderate or severe pain at 3 months after total knee replacement. We do this by using the Oxford Knee Score, or OKS, and we're looking at the specific pain scale, which is half of the questions on the Oxford Knee Score. And we're looking for a score of 14 or less. And this score was validated as part of our program. And the reference there is if you want to have a look at how we did that. Once we find these patients, they come in for assessment referral. And the way that we screen them is we essentially sent out the Oxford Knee Score to every patient who had a total knee replacement at the participating hospitals. And by doing that, it was just simply a post out to the patients, and they are the gatekeepers to whether they're eligible for the pathway or not, using this patient recorded outcome measure. So the surgical team doesn't have to do anything to screen the patients. We just simply send this Oxford Knee Score in the post. Those who do meet that pain threshold have a 1-hour face-to-face assessment clinic appointment, and this is with an extended scope practitioner, physiotherapist, or ESP. And they spend an hour with them, and this starts with, tell me your story. Let's go back to when you first experienced knee pain. Tell me what happened from there and everything that happened all the way up to today when you came into this clinic. There's also an extensive physical examination, a review of x-rays, pain scores, and blood tests if deemed necessary if there are any signs of infection. And at the end of the appointment, the ESP says, okay, based on all of this, here's what I think the problem is, or the problems, and here's what I think we should do about it. Writes referrals to put them on the right pathway for treatment, and then they go into follow-up. So they get a phone call about 6 weeks later. Have you started your new treatment? How is it going? Do you need something else? And we have the same person who saw them in clinic follow them up by telephone. And this is to provide continuity of care. We know that continuity of care improves outcomes. And also our stakeholder work with patients brought out a very strong theme of patients who are so tired of telling the same story over and over and over. It's nice to have the same person who knows you. So the follow-up continued with the same clinician over the next 12 months, up to 6 phone calls. This is a more detailed outline of the care pathway, and you can see following the assessment, there are many different factors that we were looking for. Some people were just slower to recover and needed to follow up, or it could be they had already been put on treatment elsewhere, and they said, okay, we'll phone you up in 6 weeks to see how you're doing, and maybe you can go somewhere else in the care pathway. So at any point, additional referrals could be made, physiotherapy, followed by anything that might need to go back to the surgeon, such as infection, malalignment, instability. There was also a specific, we did the hospital anxiety and depression scale to look for depression and anxiety, also questions within the examination. And history, and that resulted in a referral to the GP. Neuropathic pain characteristics, that was also a referral to the GP to initiate medication. There was a pain assessment after 6 weeks, and that was mainly to say, if that wasn't working, do we need to try something different? And then a referral to pain clinic if that wasn't useful. We also looked for indications of complex regional pain syndrome, and again, that was the referral to GP to initiate an urgent referral to a pain specialist. Now, I know in speaking to GPs before, they look at this and they say, gosh, this gives us an awful lot of work to do. And that is the case. And it's something which it's good to understand where you are in this referral process. But in our development, we found that every single clinician said there's no way this is going to work unless we refer back to the GP. So that's why those referrals are there. In some hospitals, they could do internal referrals, but in most cases, we had to send the patient back to the GP, either for medication or treatment referrals. So we took this intervention that we had developed and we tested it in a randomized control trial in 8 UK centres. We aimed to recruit 380 patients, all of which were given a baseline questionnaire using the core outcome set for total knee replacement. They were randomized, and we randomized 2 to 1. So 2 to the intervention group and 1 to the usual care group, and they were followed up with questionnaires at 6 and 12 months. We already knew quite a lot about the usual care and not a lot about the intervention, and that's why we ended up randomizing 2 to 1. Also, we were finding patients who may not be aware that their pain was chronic pain at 3 months, and we felt it would be better to offer the intervention to more people as part of this trial. Our outcome measures, so the primary outcome was the brief pain inventory, both pain and interference, but we also collected the full core outcome set and collected resource use. So how many times have you been to your GP? Have you had any medications, new prescriptions? Have you had any hospital appointments? We also pulled data from each hospital on hospital attendances, emergency appointments, and those sorts of things, and patients completed them either on paper or online. So fast forward about 5 years and we published our results. They're in Lancet Rheumatology if you would like to look them up, but I will take you through them, the nitty-gritty of them. So what did we do? We had to assess over 5,000 patients in order to get our sample. So 5,000 patients were assessed for eligibility or sent this Oxford knee score. We got about 2/3 of them back, which actually is quite good for a postal questionnaire study. And from those, after we filtered it out, those that weren't eligible and didn't want to take part, we had 363 patients who were randomly assigned to either the intervention or the control group. We followed them up at 6 and 12 months. We had a much better follow-up rate than we had anticipated. We thought we might be able to retain 75%, but we retained over 80. So we ended up doing perfectly fine with 213 in the intervention group and 100 in the control group. And these are the results for our primary outcomes. So you will see the STAR intervention is in blue, and the usual care group is in red. On the left-hand side, you have the brief pain inventory severity score. The minimal clinically important difference here is about 0.70. You can see both groups started about the same, and in fact, the control group was a little bit better to begin with, but you can see at 6 months, both get better. And at 12 months, both are better, but the STAR intervention group has less severity to their pain. And it's fairly the same for interference, whereas both groups start with about the same score, and those who received the intervention had a lower interference score at both 6 and 12 months. So the results are essentially this. The severity score was minus 0.65, interference minus 0.68, and we found it was also cost effective. So the incremental net monetary benefit was £1,200 at a £20,000 per QALY threshold. So that means a lot to health economists, not much to me, so I'm going to put it out in plain English. So essentially, when you look at the NHS perspective, the intervention group cost £724 less over 12 months. And that was essentially because they had fewer inpatient stays. And we looked a little bit deeper at the data, and we found out actually those who had the intervention had half as many inpatient stays as those in the usual care group. And those who did have inpatient stays, they were shorter by half compared to usual care. But also from a patient perspective, so we asked people about how much they worked, and in each questionnaire, how many unpaid days off work did you have over the last period of time. And actually in the intervention group, there were fewer unpaid days off work, with a mean difference of just over £300. So that's benefit to the patient there. So overall, it's an effective, cost-effective treatment which can improve pain and interference and function for patients who have pain 3 months after knee replacement. And with 20,000 patients per year at £700 per patient, that could be a cost savings of £14 million per year, which includes 12,000 fewer hospital admissions. So what does that mean to primary care? Well, the referrals. So this is what might really be relevant to you. These are the number of referrals that were made for the participants in the intervention group, and I've circled this in yellow. The GP referrals were primarily for neuropathic pain characteristics, also for anxiety and depression, as per protocol. But what's really interesting is those that qualified for those referrals in the end said, well, actually, I don't want to be referred. My anxiety and my depression was due to the fact that I'm still in pain and I don't know what's wrong with me, which was quite interesting. But the neuropathic features are really interesting. And we took another deep look into this because there were so many referrals for neuropathic pain. And we looked back in the data and we found out that actually with our neuropathic scores, or neuropathic pain characteristic scores, which are the DM4 and the pain detect, that 3/4 of the patients in the whole sample had neuropathic pain characteristics at baseline. So we wrote this up, and this is available in the Bone and Joint Journal. And the take-home message of this is that neuropathic pain characteristics are incredibly prevalent in patients who have pain 3 months after knee replacement. So up to 3/4 of people report chronic pain at 3 months that have neuropathic symptoms. And a year later, at 15 months after their knee replacement, it's between 1/4 and 1/2. So it does persist afterward. And this is something to keep in mind if you do have a patient who comes to see you with pain after knee replacement, that it is likely some kind of neuropathic characteristic or component to their pain. We also did some qualitative work to get the patient perspective on pain after knee replacement. And I believe you met Andrew Moore a little bit earlier in the day, and most of this is led by him. And I'll sum up his papers. So we interviewed patients who took part in the trial, and the big takeaway from this is most people are not prepared for the severity or the impact of their postoperative pain. And if you read this paper, the word horrendous comes up so many times, and also referrals to childbirth. And one participant said, I would rather have 10 babies than go through this again, because when you have a baby, at least the pain comes and goes. With this, it just stays with you and there's nothing you can do about it. We also did interviews with patients who had pain for a much longer period after their knee replacements and had not sought any help for it. So we specifically looked for people who had that 14 or less on the Oxford knee score pain component, but also had not had any appointments in the time after they were just discharged from their knee replacement. And the interesting takeaway from this is they don't seek help because they don't think anything can be done for them. They have a sense of futility. Why bother? No one will help me. And this kind of goes back to what I was talking about before, where the surgeon says, oh, your pain's all a normal part of the healing process and your x-ray looks fine. But what we know from the STAR trial findings is that very few patients had a problem with the actual surgery or prosthesis. I think it was less than 5% that actually needed to go back to see a surgeon for something that required intervention. The majority of them, either it's stiffness or neuropathic characteristics. So what next? We spent, if my patients don't respond to the questionnaire but present to the surgeon, can we refer directly into STAR pathway? That's a very good question. So it depends on whether your local hospital is running the STAR care pathway or not. We're still working on getting this up and running in the NHS. And unfortunately, getting research findings in practice is not as easy as you would expect. And I'll try and answer a little bit more of that with our next steps. Yes, MBT, absolutely. If they haven't had their questionnaire 3 months after surgery, the person to contact is Bincy Thomas, and it's just bincy.thomas, THOMAS, at nbt.nhs.uk, and she manages the STAR Clinic at NBT. Right, so what's next? So the next thing we wanted to do is look at the long-term follow-up, because one of the big questions that was hovering with us is what happens if a patient is in the trial and they don't have any costs for about a year, but then all of a sudden the costs go back up again. So we wanted to see, do the costs go back up after a year? So we followed up the patients for 4 years after they were randomized. And we also wanted to see how we could put this into practice. Oh, thanks, Sam, for popping that up. It's actually Bincy.Thomas. Sorry, I wasn't very clear about that. So I'll tell you about our work to put translation into practice. The long-term follow-up, if you would like to read more about that, essentially the gist of it is it continues to be cost effective. And at 1 year, the cost savings is just over 700, but it slows down after that, but it keeps going. So the cost savings goes not quite to £1,100 after 4 years. And it continues to be clinically effective. So patients continue to get a little bit better, but most of the relief for both finance and pain happens within the first year. And in order to support translation into practice, we tried to run an implementation pilot at our local trust in North Bristol. We presented a business case to the NHS managers. Look, we'll save you lots of money. And they said, COVID beds, we're a little bit worried about the winter pressures coming up. So we had to go away and come back with the data on the inpatient stays and admissions. And that's what got us the permission and funding to do the pilot. So we ran the pilot for 3 months, and we managed to successfully screen everyone who had a knee replacement and get those who were who did have chronic pain into the clinic. It all worked fine, and we learned quite a lot about how we needed to adapt things from the trial to run in the real world in the NHS. It's now permanently part of usual care since April 22, and we're setting up this in Exeter and Birmingham. These were trial sites, and our difficulty we found in engaging with other centres is that in the trial, we spent an entire day training the extended scope practitioners in the background to chronic pain after knee replacement, but also how to perform the assessments, how to interpret the questionnaires, how to read the x-rays, and all the things that you need to do, and also the referral process and what to do in follow-up. We also had quite a large manual that had lots of Q&As in them and information on what you might need to know while you're delivering the STAR care pathway. So this presented a problem because we couldn't offer that full day training and the manual and the follow-up and support to everyone that we did in the trial. So we need to figure out a way to make this work for the wider group. And in some trusts, people just had left or didn't have the capacity to deliver. So oh, the other thing I should say is we're also working with a group in Australia to adapt this for the Australian healthcare system, which is interesting. They're currently running a qualitative study Oh, I see a question coming up. Do I have any data to why patients are not prepared for the post-operative pain? I also would have thought this is something that would be discussed as part of the consenting process before the procedure. This is something I will cover when we get into my knee plan, because often a lot of patients just think if they can get in there and get their surgery, then everything will be okay, which isn't necessarily the case. But also, patients aren't necessarily getting the information before their knee replacement, and often they don't get a ton of time with their clinician when they go in for the consent process, and it might be forgotten. Although some clinicians will very clearly say, you're going to be in a lot of pain. You're going to hate me. You're going to come back in, 2 weeks and wish you never met me. But I'll talk about that more in my new plan. Um, right, so we're working with a group in Australia to work on adapting this for the Australian health system, and we developed a training package which is available on the NHS Learning Hub. So if you are interested, everything that you need to know about delivering the STAR care pathway is on the Learning Hub. I think you just need to put in knee star or something like that in the search on the NHS Learning Hub. And there are two different modules here. So we have an introduction, which is a short, probably depending on how much time you want to take at looking at all the links that they give you, maybe 15 minutes, maybe 20 minutes. And then there's one on delivering the STAR care pathway, which is essentially an online version of the training that we gave during the trial. And it has a lot of videos and information on how to conduct the entire clinic, from the history to the examination, interpreting the scores, the pain scores, and all the things about neuropathic pain. So that's available on the Learning Hub. And again, the introduction to the STAR care pathway is something that we actually put in for general practitioners, so they understand that when the referral comes in, if they want to know a bit more, here's something that you can get an overview with in a short period of time. So that's available on the Learning Hub. So what about preventing these poor outcomes in the first place? Because STAR is a very reactive situation. So STAR is, can we fix pain after knee replacement? Well, we've got a treatment for that. But let's go through the research cycle and see what we can do about preventing the poor outcomes in the first place. So yes, 1 in 5 people have chronic pain at 3 months, but also 1 in 5 are dissatisfied, and they're not necessarily the same people. It goes down to 1 in 4, or up to 1 in 4, I should say, if they are younger patients. We know that satisfaction correlates with expectations, pain relief, and your hospital experience. So enter my knee plan, which is, let's just go to the very beginning to see if we can prevent people from having the knee pain after surgery in the first place. So we want to develop a new care plan delivered by a named professional, providing continuity of care to make sure patients receive the support, care, and education they need before and after knee replacement. And we've done a national survey to see what care is given to people on the waiting list. And interestingly, very few trusts are doing prehabilitation now, or even education classes. And this, I think, sort of answers that question on why aren't they prepared. Knee schools have essentially got cancelled for COVID and never got started back up again. So we want to be able to provide this in a cost-effective manner and improve patient satisfaction and outcomes. So we're looking at known factors for poor outcomes. We've conducted a study of cancellation of surgery, an interview study, and we're currently just finishing up a Delphi consensus study. All of these things go into a co-production process to produce the care plan. And this co-production panel is a group of 15 people, 5 clinicians, 5 researchers, and 5 patients. And they all have equal decision-making weight. They all work equally as partners in managing and making decisions about this research. And we're also using the NIHR Involve guidance on co-producing a research project. This is our co-production group, and we've got physiotherapists, nurses, psychologists, surgeons, and we're very proud to have Christian Mallon, a GP, on our group as well to give us input from the primary care perspective. So I'm going to tell you a bit more about the cancellation study and interview study and how they might relate to your practice in primary care. So cancelled operations. This is something that over the past 15 years I've heard time and time again, but it just felt like more in the past 5 years that a surgery gets cancelled, rescheduled, both from the patients and from the clinicians. So I looked into the literature when I was writing this grant for my knee plan, and all the literature on cancellations for knee replacements were single center. The rates were about 5 to 23% worldwide. And I found one paper in the UK, which was single center, single surgeon, that said it was about 26%. And they had case numbers from 28 to about 1100. And what I wanted to know is, why are they being cancelled and what can we do about this? Are there any modifiable factors? Because it's such a disappointment, and you've got some financial impact as well for both patients and the NHS. Huge negative impact on patients, cancellation. I mean, you've been waiting for forever, and then all of a sudden this thing you've been waiting for has been taken away from you, and you're still in pain, and you don't know what's going to happen next. And this is an excellent paper. I picked this one just because they've got great quotes. It was like an anticlimax, like a story. A shipwrecked man survives sharks, storms, and famines, and finally reaches a desert island where he's killed by getting hit on the head by a coconut. Sometimes I wonder if they know what they're doing with people. It's probably not easy being them, but that isn't what I mean. But I'm a human, not just a number. I am a human being. So these cancellations deeply affect patients. They've made quite a lot of adjustments to their lives in order to be able to come in for this surgery, and there's a huge negative impact. There's also a loss of tariff, particularly for the short notice cancellations that happen on the day or the day before, of between £6,500 to £11,000. Most of them are on the £11,000, £10,000 to £11,000 range because of multimorbidity, and this contributes to the long waiting lists. If you cancel someone, your waiting list doesn't go down. A recently published paper by our group in Bristol did a national joint registry analysis, and there is such a big deficit in the waiting list that it would take until 2031 to eliminate it if we immediately expand our capacity back to what it was in 2019 and push it up by 10%. So we've got a lot of work to do on the waiting list, and anything we can do to bring it down will help, but not. There are a lot of things that need to be done. We specifically thought, right, let's see what we can do about cancellations. So I wanted to look at the last 5 years, so I get a bit before COVID and a bit after COVID. We looked at 6 hospitals, 3 in England, in the Southwest, Midlands, and North, and 1 each in Scotland, Wales, and Northern Ireland. These are all acute hospital trusts, and at this point, we didn't have enough elective centres to get the data that we needed, so we stuck with the acute hospital trusts. We found in all of these reports there were good reasons from the hospitals, but no clinical reasons. So all the reports said patient unfit. So we had to ask the teams to go into the medical notes to find the specific clinical reason, because this is important to what we're doing here. So they anonymized the data, sent it to us, and we coded and analyzed it. And in the 5 years, we had over 9,000 cancellations. During the same time, about 17,000 total knee replacement procedures were completed. So the cancellations account for 55% of the volume of surgeries that actually got done. And the range is between 40 and 87%. And when I presented to our co-production group, one of the surgeons in the group, their data was in there, and the face that dropped. Yeah. So pretty stark numbers. We looked at them by year, and interestingly, in 2018-19, there were about 23.7% of the cancellations, but we're back up to that now in the 22-23 year. So it's interesting to see how they spread. They haven't gotten less, and they're growing now after we've come back from COVID. Timing of cancellation. So the interesting thing is most of them happen between 2 and 14 days, which perioperative care would call a postponement, the silent cancellation. But 25% of the cancellations happened at short notice, within 24 hours. 1 in 4 happened with 24 hours. The reasons are mostly institutional, which means the hospital made the decision to cancel, 24% for patient preference, so they just wanted a different date, and 19% were clinical or not fit for surgery. The top reason for short notice institutional reasons was bed unavailable, but also list being overrun, staff not available, being replaced by an emergency patient, theater equipment being unavailable, and unfortunately, administrative errors. The clinical reasons, there were so many, they almost don't fit on the slide, but the top reason was a cardiac condition awaiting an investigation or specialist review. And these were people waiting for sometimes angiograms, but usually an echo or a 24-hour tape or Holter monitor. Maybe they'd had their investigation, but they hadn't seen the cardiologist yet, or they'd seen the cardiologist, but no one can find the letter because they were seen in one hospital for their cardiology opinion, and the knee replacement is done in a different hospital. So not great, but being cancelled at short notice because we're waiting for a test result doesn't seem to be very fair. So over 9,000 cancellations in a period of 5 years. This is the first multi-center study of knee replacement cancellations. 1 in 4 occur at short notice. And the institutional reasons are actually generalizable to other surgeries. We sat and looked at this, and actually beds not being available, not having staff, not having equipment, not having enough time on the list. This could happen in any procedure. And the clinical reasons, waiting for an investigation, treatment, or specialist opinion. That could be any procedure that requires a general anesthetic that would have this happen. And we really need programs to provide early optimization and monitoring so that we can reduce those. The financial implications of loss of tariff for this study total between 15 to 26 million, or 500 to a little almost 900 per year per hospital. If we could just prevent one short notice cancellation per month, we could fund a full-time arthroplasty specialist nurse with a support team to run a care plan to prevent these cancellations and prepare people for surgery. What this doesn't include is the cost of primary care, because what happens when the patient gets cancelled and they say, we're really sorry, this needs to be sorted out, they get told to go back to their doctor in many cases. So this has a cost implication and also a workload implication to general practice. So 1 in 4 cancellations occur at short notice, and there are a lot of effects that come with this. And we could reduce them through targeted efficiency and optimization programs. Which brings me to the qualitative study. So we did 40 interviews with patients and clinicians to understand the patient experience of having knee replacement. So we talked to people who were both before and after. And we also talked to clinicians about their current views on how care is delivered. And patients overall felt communication was a problem. They felt left in limbo. They didn't know who to contact. They felt staff were too busy. They also described changes in their mental health before and after surgery. A few people said they had really good information, and those were those who had knee school available in their hospitals. However, that was very few. Most felt unsupported, left in the dark, and they just said, I just want to know how to prepare, what to expect at when, from the point I'm listed to the point when I'm going to get better. But also overwhelmingly, they felt between when they were sent home and they had their next appointment, they really didn't have the support that they needed. They weren't prepared for the pain, which echoes Andrew Moore's work, and they didn't know how to sleep. No one told me I wasn't going to be able to sleep, and they would like support to understand how they can get a good night's sleep. And we know that sleep and pain are bidirectionally linked. If you don't get a good night's sleep, your inflammatory response goes up, not great when you're recovering from major surgery, and then you might not get another good night's sleep because you're not able to cope with the pain. They also, every patient said they would prefer someone to check in on them after they went home. Clinician themes, communication was another thing. Again, very strong. It was the top theme that came out. They thought it could be improved for patients, especially updates about waiting time. They felt that time spent waiting should be used to prepare and optimize patients for surgery. Why are we cancelling them 2 weeks before their operation when they've spent 2 years on the waiting list? That was a big theme. Every clinician I asked said, oh, our hospital has the longest waiting times in the country. But they all felt that they were too long. And this was due to staffing issues, which affect efficiency in theatre and also the bed availabilities. And they felt that there's this aftermath of COVID where many people had left. They didn't feel like they were sort of treated well during the pandemic. They're exhausted. And also theatre teams change on a regular basis, and that affects efficiency. I asked them all what if they had a magic wand, what would their ideal care plan be? And that all went into the Delphi study, and I'll show you the results of the outline care plan in just a minute. From a primary care's perspective, so we had several participants from primary care, first contract practitioners, general practitioners, and I actually managed to find one general practitioner who had also recently had a knee replacement. And they all felt communication was an issue. And they said, we have nothing from referral to discharge. We refer the patient and we know nothing until we get the discharge letter, except for when perhaps the patient phones up the secretary to say, you know, I'm in pain. When is this going to happen? And they say, go back to your doctor. Huge source of frustration for the general practice staff that we talked to. They said, this it's ridiculous because I've sent them for a knee replacement because I've exhausted all treatment options, and they're sending them back to me when there's not much more I can do for them except help them manage their pain in the interim. The difficulty, I suppose, we have is it's a bit of an unknown process once they're referred. We don't know the process, the waiting times, you don't have any feedback, which is often what the patient wants to know. The reality is we don't particularly know when people are going to go in until you get a discharge letter to say they had it. Nothing. Optimization. So some GPs would prefer to manage this themselves in primary care. Others feel that this is a responsibility of secondary care, which is something we're trying to pick through. Also, some frustration being contacted by pre-op or after a cancellation to say, please, could you quickly optimize these patients? And that's when they say, well, you know, it just can't be done in 5 minutes. And they said, those are modifiable things that we could be managing. Certainly, you know, if you got a 2-year wait, that's a great opportunity to get it under control. I think, you know, sometimes the expectation you can sort some of these things out in 5 minutes is unrealistic a bit. And waiting times. Consensus from all the primary care participants was waiting times are too long and the process is unclear. It's very vague how this waiting list works. And it would help to have transparency on the waiting times, how this works, and where their patients are on the list. It'd be much easier if we had more of a fluent way of conversations, and information access to different people's information and data will be really helpful, you know, live access to waiting times. So we've pumped this all into a Delphi consensus study, which has all the individual components that could be in the care plan. And this is what the outline looks like at the moment. It's not very detailed, it's just an outline. But we're essentially saying from the point of listing, we need a My Knee plan first appointment where you do a preparation plan to start optimizing straight away, providing education and providing exercise prehabilitation. And this should be an ongoing process during waiting, that the optimization, the treatment and monitoring is ongoing, that education and prehabilitation should be ongoing, tailored to the patient's individual needs. There should be a helpline with a phone number and an email. There should be check-ins regularly where needed, and there should be a pre-op check. So, for example, a phone call reminder a week or two before the knee replacement to check health status, to check that all those referrals, those treatments, those tests that have been going on have been actioned, and to stop taking any medications, their clopidogrel or whatever they need. And then after the knee replacement, to provide some post-operative support, advice on how to sleep, manage pain, and a check-in phone call, maybe 2 weeks after surgery, and also some advice and support around kneeling. So that's where we are at the moment, and that's all I have to say with, I think, a minute left. So thank you very much for your patience. I'm sure you're all very eager to get on with your Saturday, so thank you very much.
Thank you so much, Wendy. That was brilliant. Thank you. Brilliant.
Thanks very much. I don't think there's any new questions there.
I didn't see any come in.
Oh, here's another one here. Is there a role for looking more into patient education on chronic pain and realistic expectations overall? You often get the feeling that people fail to realise that even after surgery, things will not be perfect. and suspect that this has an impact on their ability to manage post-operative pain. This is the case in many other surgeries or chronic health issues, and everyone wants a pill and a quick fix.
Yes, yes, I completely agree. And the term that I really don't like is new knee. People think that they're going to get a new knee, like they're going to get, you know, a new set of bookshelves. It's not quite the same. And what we want to do as part of this care plan is set realistic expectations. And we know that satisfaction is related to expectations. So that's why we want to have sort of education all the way through, from the point of listing to the point of surgery. So we can maybe make those a little bit more realistic with education.
Yeah. Yeah, totally agree, isn't it? And Hugh's just put really interesting, can relate to so much of this. Really interesting are the neuropathic element and post-op pain. Definitely.
Yeah, and if you want to learn more about that, check out the Bone and Joint Journal. There's a really nice, intricate look at the individual symptoms and where they occur, if you want to learn more.